My name is Mark Sonnenmoser. I'm the Trauma Stroke Manager at Mosaic and a student at Excelsior College. This presentation is entitled Care of the Trauma Patient, the First 30 Minutes. Trauma is an extremely time-sensitive process. This presentation will focus on certain key behaviors for both Level 1 and Level 2 activations, as well as those elements of team behavior that guarantee success. Key skills. These are: the learner will be able to state the criteria for Level 1 activations, also state the procedure for activating the trauma pre-arrival pre-registration, and determine the need for nursing attendance during imaging procedures, implement Level 1/2 activation order set, and demonstrate SBAR communication. Finally, demonstrate the steps of escalation as needed. Essential to Level 1 activations is a trauma pre-registration process. The pre-reg identity will be replaced by the patient's name and date of birth when they become available. There will be an updated ID band. The key behavior on the part of the ED staff here is to leave both the pre-reg and updated ID band on the patient. The encounter number must be verified to be identical on both ID bands. The medical record numbers may be different if the patient had a prior visit to Mosaic. This will be observed and documented by Access staff. A chief deliverable of trauma pre-registration is to initiate the massive transfusion protocol. Make certain to ask a physician of record, either the ED physician or trauma surgeon, whether to administer TXA. If there is any doubt, order it as part of the MTP. At this juncture, the TXA is an inexpensive drug. The MTP protocol is usually a Level 1 intervention that can be needed and used on any trauma patient. A key behavior that we will observe is the initiation of the MTP order set on Level 1 activations. When the triggers for MTP are present, get the cooler ASAP from blood bank. Our trauma medical director wants us to initiate this on all Level 1 activations as a matter of course. In this way, we will also maintain confidence in what is a complicated process. By the way, this slide shows the new MTP coolers, which will soon replace the igloos we use now. Level 1 criteria are fairly concrete. They are derived from the Resources for Optimal Care of the Injured Patient, published by the American College of Surgeons Committee on Trauma. We typically determine these from EMS reports, but if the patient meets the criteria at any point, including after ED arrival, the patient should be made a Level 1. Our key behavior is the appropriate trauma activation as evidenced by documentation on the ED trauma form. It is a given and covered in our standard that all Level 1 patients will be accompanied by a nurse to imaging procedures such as ultrasound and CT. The key behavior concerning Level 2 activations is that the attending trauma nurse will talk to the ED provider on the need to accompany the patient. While the provider's opinion is important, what is desired most is that both nurse and provider consider elements such as mechanism of injury and clinical signs that might predict decompensation. This will be documented as a timeout on the ED trauma form. This is an intentionally busy slide. It contains an assortment of actual Level 2 activation pages. All meet criteria, but there is no way to determine which of these will actually be more serious on arrival or decompensate after they get here. The Level 2 timeout is intended to counter a cognitive error known as premature closure. This is when one decides one knows what is wrong with a patient or how sick they are and then looks no further. The Level 1/2 activation order set is a quick and convenient way to get diagnostics started for all activations. The point of the order set is to avoid missed injuries. Most advanced imaging is not included as default orders, so the provider of record should be consulted about what to order. The key behavior is the initiation of the order set in Elmer. We tend to assume we do not miss injuries. In fact, confirmation bias is a common problem, such as when one witnesses an obvious problem, such as is noted on this slide, and ignores other presentations. This is actually necrotizing fasciitis that is due to or secondary to an injury. On the other hand, injuries such as this pelvic apophyseal avulsion fracture can be missed if the need for imaging is parsed too closely. This is typically a sports injury seen in the young, but it illustrates the principle of major trauma management. We should err on the side of overassessment. The key behavior for this order set will be its initiation in the medical record on all activations. SBAR communication. For this slide, we could use the famous Firefox phrase, well, this is embarrassing. The point is, when people think they are communicating well, they are often failing on a very basic level. SBAR should be a standard approach when communicating about patients during handoffs or explaining an issue to a provider. Almost all communication failures around these two events result from a failure to use the communication technique properly. The more you use it, the more level the communication field will be between you and other caregivers. SBAR is referenced in numerous standards, including Medical Emergency Team and Code Blue. The key behavior will be the observed use of this communication technique during patient reports. Escalation occurs when things do not work as intended and the patient is at risk for an adverse event. SBAR communication has been attempted and has failed. The intensity of communication should be reflected when you do this. This does not mean that you lose your focus, use curse words, or insult people personally. All these behaviors will diminish the impact of your message. Escalation should occur along the chain of command per our standard. Keep in mind that an issue with medical staff decision making may require you to use a parallel pathway along a medical staff chain of command. This would take you to the emergency department medical director or his designee, or perhaps the trauma medical director. There are also very specific resources to use on trauma alerts. The key behavior for escalation will be the observed use of the chain of command. Later this month or the beginning of November, you will be asked to participate in a training exercise. There will be several unfolding case scenarios. Each scenario will deal with the key behaviors to one degree or another. Each scenario will also require some critical thinking and team communication skills. Trauma training traditionally focuses on improving the technical skills for a particular discipline, whether nursing or physician. These exercises will concentrate on interdisciplinary communication. We tend to think about teams as the numbers of staff available. However, we have all seen too many people in a resuscitation room. Teamwork is about effective communication and effective role playing. Team functioning will be evaluated looking for behaviors that demonstrate leadership, feedback, cooperation, coordination, respect, and the ability to overcome barriers. Everything we know and all of our skills mean little if we cannot function as a team. Interprofessional training and debriefing are ways we can improve our team skills. Team functioning, especially when it is highly focused on common goals, tends to both prevent errors and mitigate identified errors before harm occurs. 2, 3, or more heads are really better than one. Thank you for your attention to this material, this presentation. In the next couple of pages, you will find my references as well as the image citation.